Hello and welcome to our webinar, Building a Virtual Nursing Business Case. Um, this is session 3 of 6 virtual nursing classroom series that we're having once a month. And we'll be very focused on the business case for virtual nursing this time. And I've brought a friend and colleague with me, is Dana Pico, and she is our Director of Clinical Sales. And Dana, do you just want to talk a little bit about your role here and what you've been doing since last October?
Sure. Hi, everybody. I'm so excited to be here with you. My role is to help you build out your virtual nursing business case from a clinical perspective. I've been here since October and I've visited over 30 sites, already helping other organizations try to build their virtual model. I come alongside one of my colleagues who's a technical engineer, so we kind of tag team it and we meet with both your clinical teams and your IT teams to just help you design a strategy and a business case to move forward with the virtual platform. So I'm really excited to be here and I hope to meet many of you in the very near future.
And you're a nurse.
And I am a nurse. Yes, I
Yeah.
am a nurse. Thank you. Yes,
I'm Director of Clinical Sales, yes.
yes,
With the kiddos a lot, right? A
yes,
lot of pediatric background. So
exactly.
I've really been loving working with you. And I think I didn't say it, but I'm the Chief Clinical Officer for Avasure and also a nurse. Um, and so Dana is like our field reporter. So I'm going to be like, so what are we hearing out in the field, Dana? To you, and so you can talk about what you've learned because as they say, if you've seen one hospital, you've seen one hospital, and you've seen 30 some in the
Yes.
last short period of time. So what we're hoping to cover today on a kind of a brief outline, and please use the chat, by the way, or the question box, we're gonna be throwing that in and want to make it as interactive as possible. So I'm just going to spend 15 or 20 minutes talk about getting started. Our August webinar is about scaling your virtual nursing program. So I think this is going to be a little more focused on where do I get started and where can I get like a great business plan right out of the gate. Who do you have to partner with? Some tidbits that we can offer about maybe where to find some initial funding for a program and choosing the best setting. And then we really want to get to the meat of it is where can you quantify cost savings from a virtual nurse program and kind of connecting the dots to this is what a virtual nurse can help with, but how can we measure that in a financial way, which is so important right now. And so let's get started. This first slide I'm going to show you, and this is hot off the press. Here at Avasure, we commissioned a virtual nursing insight study recently and actually just kind of got our presentation from the Jocelyn Insight marketing research firm yesterday. And just to say a little bit about Jocelyn Insight, they have worked with AONL and the American Nurses Association and the Daisy Foundation. They are really experts at market research within the nursing and patient care space. So this is a survey that had 789 respondents in healthcare leadership positions. And it was from them, so it's not, respondents wouldn't have known that it was an Avasure sponsored market research study. So we got some unbiased feedback from this market research. And the types of respondents, I think, were very similar to the types of people that and roles of people who have registered for this webinar, actually. So everybody thought that 94% thought that virtual nursing will become an integral part of care delivery. And then when they pulled out just the chief nursing officers, it's 99%. So if you're in the 1% naysayer, you're probably not on this webinar. But so I think we all know that it's happening, but how do we measure it and how do we get started with it? So I think just to go to the next slide, one of the big questions that we asked is who leads it? Who's the primary decision maker? It is often, and most often, the chief nurse or chief nurse executive officer. What have you seen too, Dana? You had some insights on this
Sure.
when we planned.
So
Yeah.
part of our role is like like I said in the beginning, is to come on site and start talking about what your virtual strategy is. And all too often, my colleague who I travel with, who's an IT engineer, he goes and speaks with the IT folks. I speak with the clinical folks, but then we bring them together, and we quickly find out that they're both talking to different vendors about their IT strategy. It's so nice to bring you all together into one room and have you have a dialogue as to what your needs are from a clinical perspective, and then what the IT needs are and what they're looking at. So that's part of the whole strategy too, is to not to work in silos anymore, to actually collaborate, work together. If you're not talking to your IT partners, I strongly recommend you start, because if you're looking at a virtual care strategy, I'm sure they probably are as well. So that way you can collaborate, work together, and kind of augment the entire process to move forward with your whole virtual care environment.
Exactly. And on that, let's run a poll here to see from the audience who has a go-to IT buddy that you work with, and what is the role. So are you working closely with your CIO? Are you one of the lucky ones that has a CNIO, or is it an IT architect or IT analyst, or another one that we haven't thought of, or help, I don't have one. So let's see how this pans out and who people are working with. I know there are some people who are in this role themselves, so check yourself if you're on if you're on the call and you're one of these roles, like you're your buddy. I'll give that a minute or a few more seconds to run.
And I know I've been seeing a lot as well. A lot of the other organizations are also enlisting the help of a CTO. So that's been an emerging executive on the team that's really looking at the technology and looking at the entire landscape. So that might be able to fall under your other criteria, because I know a lot of organizations, especially large organizations, are really heavily focused on that as well.
Yeah, and if you have an other that you think is important, feel free to just type it in and
Absolutely.
the question box. Okay, so IT architect, IT system analyst is the most common. Few are looking for that person. And so I think maybe a to-do is to find, go have coffee with someone and start to partner up on that, because I've heard that too, Dana, when I'm interacting with our health system partners, that there might be something going on in the other in another department and they've forgotten to ask,
right.
What are you guys doing? Or if you've gone through the whole process and didn't bring the IT in early, then that really extends the process, because then they have to go through their vetting process and they have a different lens. So it's great to bring them early so you can do that work in parallel and be more efficient.
Right.
I know my friend, and the next poll I'm going to add just another team member is someone in finance who can really be buddy up with you. And so who is your go-to partner in the finance side? This is really important as well. Is it the chief financial officer? Is it a controller? Is it at a director level? And help, I'm looking for one here too. I know that a friend of mine, Patricia Mook, had signed up for this webinar. I'm not sure if she's able to attend. Oh, she is. But Patricia, did a fantastic presentation on virtual nursing at the AONL conference. And you said this was so important, that you find your person and part of your success. And I've even heard of, and have kind of done this trick myself when I was a clinical nurse specialist, was utilize interns. So the Master's in Healthcare Administration intern can be someone who can be your arms and legs and go do a time study, or just really dig into the data, dig through your sitter data and find out how much sitters you're actually using. So great. So that kind of that middle level, that director of finance, is somebody that a lot of you are able to use for this. So, and controller, maybe that's not a health system term. We use that we do have that here at Avasure. Okay, great. So that's one of the key parts is, bringing that team together for success. Do you have anything else to add on that before we talk about where to find funding, Dana?
So I think just to your point is bringing everybody to the team really helps hear everybody's side of the story, right? Because we know we're depleted of nurses in our organizations. So we have to, from our CNO partners and our CNIO partners, that's one of their priorities. But I'm hearing in the market as well, we're also depleted in a lot of our IT resources. So having them early on, having to hear what the discussion is, what the lift is for them also contributes to the discussion, because I keep hearing from multiple organizations that with the remote working that they're losing a lot of IT folks to different organizations across the country, and they're struggling as well. So if we all work together collectively, have this dialogue, let them know what's the expectation. If you deploy a virtual strategy, both from a clinical perspective and the IT perspective, it really helps to kind of drive that adoption, get the ball rolling, and let everybody be at the table at the same time and make those decisions.
Somebody wrote in another title, which is awesome, and you're lucky to have this, Manager of Transformation System in the ITS digital health and transformation space. So even, I'm seeing that too, the chief digital officer can be someone who's great in that organization too. So thanks, Kirsten, for writing that one in. And then I just have like a few tips or tidbits that we've heard for finding that initial funding. So one source can be, a lot of health systems have a vacancy rate right now. I think the average is about 15% and it can be much higher. So if you do have a vacancy rate and you're doing everything you can to recruit nurses, you do have that allocated maybe in your budget. And that could maybe be used, or part of that could be used for staffing a virtual nursing program. So that's one creative way, and maybe retaining some of those wisdom workers and having them fill the vacancy. Some care units are running on a higher ratio than it's budgeted for just because of vacancies. And so that budget can be used in a creative way. Another piece of advice that I heard from a system chief nurse, which I thought was really valuable, and that was actually someone on our chief nurse executive advisory board, which we just started up recently. She said that she makes sure that when she does plan for this, that she allocates the funding within the hospital or at the hospital unit level, which is where the staffing is allocated, instead of, especially if you're at a system, putting it in a corporate overhead cost center. Because if you're allocating funding from a corporate overhead cost structure, it becomes a cost and maybe a target for cuts real quick. So allocating it where the care is done and where the care is recognized is an important tidbit. And then because Avasure is the pioneer in telesitting, and we have over 1,000 virtual sitting customers, that's the other thing that we see very often, is we're going to get started with the proven and very tangible ROI of decreasing one-to-one sitters, and then allocate some of those savings over to starting up a pilot using the same technology of virtual nursing program. To test out the financial model and not have another new investment. Did you have any other thoughts on that?
I think to add to that, oftentimes when I'm having this conversation, multiple organizations will say, well, why don't I just hire that nurse and have them work on the floor and just stay on that floor and go and support this team in person as opposed to virtually? And I always ask them, have you had a discharge nurse or an admission nurse in the past? And oftentimes I'll hear yes. And I'll say to them, well, what happened to the program? Well, we wound up pulling them into staffing, or they see them on the floor and they become helping hands. And as nurses, we all know we want to help our colleagues. We want to make sure that they have what they need. But if you're really looking at improving some of these outcomes and efficiencies, the best form of action is to be able to have that virtual nurse really focus on their task at hand. So whether it's admissions or discharge or education or preceptorship, they can really kind of hone in on that and focus on that and cover multiple locations, as opposed to if you have them as a discharge nurse on the unit, you have a couple sick calls and then they say, well, now we can't have you do discharges. Now we're gonna put you back into staffing. You're just kind of back to where you started, and you're really not augmenting that staff and that potential on the unit to really help move those patients through and help really support your bedside nurses from that capacity. So that's what we hear often, is why I wouldn't just, if I have the FTE, why wouldn't I put them on the floor? These virtual nurses can really augment your staffing in multiple locations, which will really help kind of drive that greater good of the whole organization, as opposed to just that one body on that one unit. So that's something to think about when you're embarking on this journey. If you've gone down this path before and you're probably you might meet opposition, this is a way to combat that and say that it's going to be really task focused, or a specific goal for that particular virtual nurse to achieve at the end of the day, and make sure that we can really help the whole organization as opposed to just that one unit. That was a long answer, I'm sorry.
Yeah, no, but that kind of transitions right over to talking about how to really strategically choose the setting and the care units to get started with. And what you were just talking about is what we advise is not to just start with one geographic location because of that objection, like just give me another body, don't give me someone virtual. And so it makes sense. And I think we talked about this at the last month with Jefferson, that they had 2 care units that were not in the same building as part of their pilot. So it made more sense for them to be virtual, and they weren't, you know, right on one care unit getting pulled into, can you just help me with this one thing? Yeah. So which would kind of throw off the whole point of studying the virtual care. What other settings have you seen be successful?
So some of the biggest successes that we're hearing about is those units with high churn rate. So you have high turnover of nurses, so you can really kind of hone in on those units. The other unit selection is, I always recommend your early adopter units. We all know those units that we identify early on when we have a new product or a new technology coming forward. They're the ones that they want to try it. They want to try everything, so that they're really open and receptive to new technologies. I strongly recommend that. The other component is, if you're going to be doing it, to Elizabeth's point, don't just isolate it to one particular unit. You really want to be able to pull in multiple locations if you can, to really get a true snapshot of how this process is going to be impactful to multiple locations. What comes to mind is one hospital that I worked with out west. They were a very large organization, so they decided, because they had 8 different medical surgical type units, they were dividing and going 4 and 4, so they can really truly benchmark the 4 that are using the virtual nurse versus the 4 that are not using the virtual nurse, and really look at things like how long it takes for that patient to actually get discharged on both settings, and looking at the admission process, and really kind of honing in and having a true comparative analysis of the organization and having like units compared to each other, so you can show, and this helps build your business case for expansion when you can show those positive outcomes. The other question we get asked a lot is, when we're having these discussions, do I do a big bang or do I do a pilot? Mm-hmm. And much like Elizabeth said about Jefferson, they made the decision to do a pilot, but they did it very strategically by having it in 2 different buildings, just so you don't pull in that virtual nurse to fulfill your staffing. That really kind of helps decrease that. But depending on the size of your organization and what challenges you want to address for the virtual nursing, Big Bang works really well if you are a smaller organization and your number one goal is throughput, for instance, and you really want to help decompress your ED and really get patients moving in and out. So that would be a good example of a big bang. But from a pilot, when you're a really large organization and you do have the capacity to do a true analysis and comparison, pilot is absolutely does well as long as you have a nice clean criteria for those units. But again, that's part of what our goal is at Avasure, is to work with you and identify those locations and kind of work through the semantics and the details to make sure that you are successful.
Yeah, building the team, yes, finding the funding, deciding where to start and how to start are those key initial decisions. But I think it's also so important to start with a problem instead of saying, we want to do virtual nursing. Let's do this model or that model and then measure what we get.
Right.
Let's now talk about what are the big pain points and how, and starting there and then designing your model around where your need is, because that's different.
Right.
In 5,000 hospitals across the United States, there are definitely some themes, but and it's very different. So you need to kind of dig. And I guess I should have put who's your quality partner, because finding out your quality data is really important as well. So on this poll question, I want to hear from you all. Where do you guess, or where do you feel are the most important domain to focus on for a virtual nursing program where you have challenges? Is it around the patient experience? Is it patient quality and safety? Is it on the nurse staffing? Or is it efficiencies and throughput? And then I think within the efficiency and throughput, we're really talking about things like bottlenecks in different areas and readmissions, like 30-day readmissions, that kind of thing. Patient experience, I think we all have pretty clear. On quality and safety, I'm talking about avoiding hospital-acquired conditions more than the nursing sensitive quality indicators. And then RN staffing, it's the vacancies, it's the cost of turnover, it's the agency staffing. So what do you want to hear? And this is a choose your own adventure. So whatever gets the highest number of votes is what we're going to talk about first. So you are creating this presentation in real time by your vote.
I'm still excited to see what they think.
Oh, it's okay. Did you guess that?
I kind of figured it would probably be efficiency and throughput, because that's a huge challenge that I'm seeing across the entire country.
Okay, so I'm writing this down. I mean, I'm sure Laura is managing this for us, but we're going first with efficiencies, then staffing, then quality safety, and experience. Okay, I love this order. Just for fun, we'll share what the Virtual Nursing Insight Study showed us with similar respondents, but almost 800 on a recent survey. So that they were a little different, but there are more categories, because GoToWebinar doesn't give us this many categories that we can do in a poll. But it looks like it's really the nurse satisfaction and retention was at the high part. Patient experience was up there. The workload burden, I think that kind of bundles into nursing experience. But throughput was not as high, but it's kind of slightly different categories. So, but we're going to cover it all. We're going to take the next half hour or so to walk through all of them. So let's get started with and as we talk about these 4 categories in where, if it's available, where you can kind of connect to cost reductions, I just want to frame it from a kind of an economics 101 viewpoint. And so I worked for 13 years at a wonderful Catholic health system. I was a clinical nurse specialist and a magnet program director. And it was one of the nuns there that told me, no margin, no mission. And it really changed my viewpoint as like kind of a bedside nurse, clinical nurse, getting more into leadership positions, that we need, the health systems need that margin, or that it's profit is another word for it, in order to move forward. And there are really only 2 levers that we can pull here. One is revenue, how much money is coming in from the payers, and then cost, and where can we control costs, because that's the difference, is the margin, and the difference is the mission. And so when we talk through, we're going to look at that lens. Most of what I think you will see with virtual nursing is on the cost reduction side. There might be some over to impact on revenue, but on the efficiencies, and so each of these categories will start with those big drivers that we all know that we're looking at. And then what KPIs can you zero in on from a virtual nursing perspective? And then where can we put some numbers to that right now, knowing that we are on still the early adoption curve of innovation within virtual nursing, not where we are with telesitter. So virtual sitting, it's like so easy. And we've been doing that for so many years. It's so easy to put dollars to, but virtual nursing is more complex. It's nursing care. It's the scope of nursing practice. So when we talk about the driver of efficiencies and length of stay and bottlenecks and the hours per patient day, Dana, what examples have you seen from this as you've been traveling about?
Sure. This is my favorite topic, by the way. This is what
Oh,
I
good.
kind of live and dream for, because in my former life I really focused a lot on this, but obviously ED holding is a pain point across the country. We're seeing people be held in the ED for as long as 24, 36 hours. And we're also seeing people leaving the ED without being seen, which is definitely something we don't want to happen in our organizations. I think back from when I was a nurse, and a lot of the nurses on the phone or on the call, you think of your day and you have 5 or 6 patients and you get that discharge order. And in your brain, you're saying you have 2 avenues to pursue. You're either going to get it done and just be done with it and check it off your list and focus on all your other tasks of your other 4 or 5 patients. Or in your brain, you say, well, if I hold on to that person, I'm not going to get another admission. I can kind of do what I need to do and then get that patient out. But what that does is obviously contributes to that bottleneck in the ED holding area. So obviously by using a virtual nurse, offloading a lot of that documentation burden from the admission and the discharge, that really kind of helps me as a nurse get what I need to have done in a timely manner, but then also know that my documentation will be completed, my admission will be completed. So it kind of helps that whole flow. I'll tell you a funny story. I was at one of my girlfriend's retirement party. She was a nurse for 30 years. And we were talking about this role. And she was, if you would just take charting off my hands, I would have stayed at the bedside. And I'm like,
Wow.
oh gosh. She goes, I spent so much time charting. I just always felt like I was in front of the computer. All I want to do is, you know, be with my patients, talk to the families. She goes, that's probably part of the reason why I'm retiring, because I'm just so tired of charting. We know we have to do it. We have to chart. So if we could take some of that off of the nurses and have it, 1, up to date, number 2, complete, and in a timely manner, it kind of rolls into the incidental overtime. I always talk to hospitals, and I strongly recommend, if you have a scheduling tool today that can capture reasons for no lunch and reasons for clocking late, make sure that your staff are starting to use that technology, especially if they clock no lunch because they had an admission or a discharge, or if they're clocking out late. You want to identify what that is. And again, this helps build your business case and help show that you're decreasing your incidental overtime, because now you're not having your nurses miss their lunch, because we know that's an additional 30 minutes of pay. And then you also have those nurses that I worked with them. I think occasionally I did it, where you wait till the end of your shift to do all of your documentation. You have napkins like this with all your paper,
Oh,
all
yeah.
your information. And so you wait until the end of your shift because you have so many things pulling you in multiple directions. You can go ahead and rest assured that that virtual nurse is doing a lot of that for you. So now you're clocking out on time. And this is a little nugget that people forget about when you're starting to look and build your business case. I really strongly suggest, if you're not capturing that today, if you're looking to do a virtual model, you really want to start to do that as soon as you can, so that way you can have pre and post implementation data, and you will show. In my former life, I worked for another company that did throughput kind of analysis. And one of the hospitals I worked at, by being able to just make sure the nurses got their 30 minutes of lunch, they were able to save almost $1 million in a year. And I foresee with the virtual nurse being very similar to having those kind of outcomes, because you're not only making sure your nurses get a break, which they need, and we can show multiple different data why that's important, But then also it builds obviously for your incidental overtime, but then it kind of drives also into nursing satisfaction. So you're kind of killing two birds with one stone if you can really implement that virtual nurse and making sure that your bedside caregivers have time to stay at the bedside and do what they need to do while they know that that virtual nurse is getting a lot of that documentation completed for them. I just love this
Yeah,
topic. This is my favorite topic.
absolutely. I completely agree with
Yeah,
all of that. It's like, I think 30 to 40% of the time is spent on documentation in it.
yeah,
And so, and where, and this is kind of that model of virtual nursing, the clinical resource nurse, that we talked about last month. And so you can see a recording of last month's webinar to see how UNC Rex and Jefferson are doing this. But there's really on the front side on admission and on the back side on discharge is where a virtual nurse can have really quantitative impact. And of course, I'm doing this because this is like we're shortening the length of stay on both ends, and length of stay is a cost. And so you're getting, no matter what your payer mix, you're getting paid for that patient's health or that visit. And so if you can do it more efficiently and shorter, that is ultimately your business case. And so and I have referenced here the article by Schulke et al. And Virtual Nursing, the New Reality, and that's number 2 down there. But they talked about and demonstrated that they decrease their dismissal time by 20 minutes. And then what's coming through quickly now in some of our pilots is being able to significantly decrease ED holding time. And then if you just like back up, and I'm an old cardiac nurse, so I love plumbing and thinking about it like this way, like you're having things back up into the liver, spleen, so if you have ED holding, you're having backups happening in your waiting room in the emergency department, and then people are being left without being seen. And that, of course, is where you might be actually even impacting revenue. And then on the hours per patient day is everybody's looking at their hours per patient day. But then looking even beyond just hours per patient day, but labor cost per patient day, which is taking your hours per patient day and making sure that you have everybody working at the top of their license. So you're not using nurses to transport, and you're not, using nurses to sit, in all those ways that maybe the hours per patient day can even be the same, but the cost can be lower if the right people are doing the right thing. And that same article that I talked about showed, between a 29 to 32% decrease in their labor cost in that mix. And then I think there's a good benchmark. I've been looking for this, and so I also threw it in here, a good reference as a benchmark. But I'm sure you all are benchmarking against yourselves month over month and quarter over quarter on those costs, and then how to plug that into your whole plan.
we
All
can
right.
talk for another hour all on this because it's so exciting and it's so prevalent.
Yeah. But let's move. The next one was the nurse staffing one. And of course, this is, everybody's top 3 priorities is staffing. And so the big drivers there, everybody's looking at turnover, vacancy, and the use of agency nurses. And I was doing like on admission and discharge. Now I'm going to use that same gesture and say, losing new grads and losing your experience. So new grads not feeling supported, feeling, scared and not having a good experience and leaving the profession. And then your experienced nurses being just worn out from the pandemic, or like your friend Dana, sick of documentation. And so there are ways that virtual nursing can help on both ends there. Do you have experience from the field reporter about nurse staffing?
It's personal. My daughter, cheers to her, she graduated in December with her BSN. She's very proud of her. She worked really hard, and she, as a new grad, she wanted to always work in an ED, and she did. She did get into an ED residency program great experience. She would share when she came home, her preceptor was 36 weeks pregnant, and she goes, "Oh, Mom, it would have been so nice," because sometimes, you know, she would sit at the desk and she would send my daughter in, and she goes, "It would have been so nice if I had a camera, if I had something, a device that I could roll in and just let her hear what I was talking to the patient about." She said it gave me great comfort that she trusted me to go in the room, but she said, as a new grad, I just needed somebody kind of in my ear to make sure that I was doing the right thing or asking the right questions or just doing, you know, what she should be doing at that time. The other use case that my best friend, they're all personal, maybe because we're nurses, we all gravitate to each other, but my best friend took over my job as a clinical nurse educator. I was a NICU nurse educator for many years. And I think we have a couple of pediatric hospitals on the line, but body cooling is one of those low incidence, high risk. You have to implement it really quickly. And so they had a kiddo. She goes, "I wish that we could do something remotely because she wanted to support her team to be able to watch them prepare and get everything set up." She goes, "But I have to drive there. So by the time they call me, I get dressed, I get in the car, it's almost 30, 45 minutes." She said, "How wonderful would it be as this educator to be on call and be able to log in and coach them through it from home?" Because I gave them all the tools they need to be successful. They just sometimes need that confidence and that cheerleader on their side saying, "Yes, you've got it. This is what you have to do." And she said, "I just know it would give them peace of mind knowing that that baby's there and they're going to start cooling, not having to wait. They can get the process started and I can be there right then and coaching them." So there's a lot of unique use cases, I think, when you're starting to think about virtual nursing. Obviously, like we said, new grads and keeping those experienced nurses. That's probably one of the key components because we want to make sure that we're investing a lot of money in our new nurses and we want to make sure that they stay with us. And in order to do that, they need to feel obviously appreciated, but also supported. That's one of the biggest drivers I hear from organizations, that their preceptors are feeling burned out and some of their newer nurses on their exit interviews felt like they didn't have the resources they needed to be successful. So by having that virtual nurse that you've identified, that's one of those warm and nurturing nurses that can really kind of precept and coach them and mentor them through their journey, their nursing journey, that will bode very well for those new nurses to stay and be committed to you because you're committing to them and their success. So these are some components that we're hearing a lot: is burnout, new nurses just not feeling like they're getting what they need to be supported. And we really need to keep our nurses in the field and happy and supported, and anything we can do to keep them there would be very beneficial.
And I put in here the 2023 NSI National Healthcare Retention Report and some of the measurable outcomes that you could come at. This is data with credible data that you could bring to your CFO or your finance colleague as you're building your business plan. So I would highly recommend looking at it. It's recent and it's based on a survey of 273 hospitals. So and so that kind of brings some gravitas to the data of saying, yeah, it really does cost $52,000 for every RN turnover. So if we could decrease our turnover by such and such percent, with this kind of support, with offloading the documentation and with mentoring, there's a huge financial impact. And they have metrics on the average current vacancy rate, which is about 16%. And just the cost of replacing agency nurses if you're able to staff more efficiently. And how do you measure that too? I know staff engagements, or whether it's a culture of safety survey or other your staff engagement surveys, they might not happen frequently enough to really measure pre and post pilot. I mean, it's definitely something to keep track of. But here at AvaSure with our virtual nursing customers, we provide a sample of a pre and post survey that you can do or tweak within your own bedside staff to make sure that you're measuring that okay, we've implemented it and it's had a positive impact on the bedside nurses. And with the vacancies, there is a potential to impact revenue. I remember I said revenue is not it's mostly on cost cutting, but you could potentially have vacancies to the point that it's impacting revenue. And so I'm mainly curious here if we could do a poll to see if you're aware in your organization, have you within the 12, let's look at the last 12 months, say, have you had unit or bed closures, or do you have ongoing, bed or unit closures? And or diverting from the ED within the last 12 months that have something to do with not having enough staff, that you have vacancies. And I mean, is there, while you're answering that, I'll throw in here what we got from Wade Batt, and he was presented with us last month about virtual nursing, and he had a recent nurse satisfaction survey that asked, has virtual nursing impacted your decision to stay at the hospital? And more than 25% said yes, with a little smile.
Yay!
Yeah, thanks, Wade.
That's awesome.
Yeah, I'm confident that you will get positive outcomes.
I think so too.
Especially if you hire the right people.
Right.
So almost 50% have had nursing vacancies directly impact revenue. Wow, I'm not surprised, but yeah, that's amazing. So there is a business case. And we talked about the new grads. Now I'm going to talk about the more experienced, how to retain more experience. Not Dana's friend, because Dana's friend doesn't like charting, but some virtual nurses just enjoy and still interacting with patients, but in a less physically demanding role. And not being interrupted, just being able to just have dedicated one-to-one time to walk through a thorough admission or just do amazing discharge education. And so the virtual nursing insight study that we did, we had strong agreement that there is an opportunity to recruit nurses who are unable or unwilling to work at the bedside physically, maybe due to physical demand. So 75% of our overall survey, and then when we looked at the CNOs, it was even higher. So it's a great tool for keeping some of your seasoned wisdom worker nurses.
Absolutely.
All right, then I think our next category was quality. And this is a little plug for next month, but we'll be presenting next month with UC Health in Colorado. And I referenced an article that they did just a couple months into their virtual deterioration program, where they saw a dramatic decrease in code blues. But now it's been, it'll be, I think, over a year since that's been implemented, and other programs. There is the expert oversight model, and Amy Hassel from UC Health will be talking about the quality impact on sepsis, wound nurses, on HOPPs, and respiratory therapists on vent days, virtual respiratory therapists on vent stay days, as well as I think, spoiler alert, it's like 1 million alarms, false alarms, that they've avoided at UC Health. So on the quality and safety side, virtual nursing has a very important impact, and we're not winning this quality war or safety war over the last few years especially. And more is emerging on that, but the Joint Commission most recent report, which just came out a couple months ago, looking back at 2022, showed an alarming increase in sentinel events. And I just put falls here. You can read the whole report yourself, but falls increased, sentinel event falls just dramatically increased over the last few years, which we're not surprised about, but quality is a huge driver. And Dana, what are your thoughts about how virtual nursing can impact quality and safety?
It seems as though, as of late, I've been hearing a lot of initiatives being targeted for like happies in the hospital. And one hospital in particular, well, actually two as of late, they have the 4x4 model, which is 4 eyes within 4 hours. And then another one is a 2x2 that they're this particular hospital is having 2 nurses do a complete head to toe assessment, skin assessment on admission and every single transfer. And one of the nurse leaders that I spoke with, she said that because the ratios have changed, her fear is that because Elizabeth and I work together for a long time, we trust each other, that I may say to Elizabeth, hey, can you come in here really quick and help me do this head to toe? And Elizabeth might say, well, I trust you. We've worked together. Don't worry, you've got this.
Yeah.
And she's like, it's not a gotcha nurse. It's not trying to get them in trouble. It's just because they have competing tasks that they have to get done and they just don't have the time. So that would be their big initiative, is to have that virtual nurse be that second set of eyes and really truly do that head to toe assessment with them virtually, so they can do the documentation and support that bedside nurse without pulling from the floor. She said that's my biggest driver, is to make sure that I keep all my nurses on the floor and I'm not pulling from them, and then this virtual nurse can augment that whole workflow. So I'm excited to see what happens with that and where they go with that, but I really think that those are some of the use cases that sometimes you don't even think about from a reality perspective, and how this virtual nurse can really help you with those
Yeah.
clinical
And then as you're doing the business plan, to really identify where are our issues, where we're at, what are
Right.
our challenges. Is it the CLABSI? Is it HAPI? Is it, County? Is it Falls? And then kind of and then on the readmissions, the same thing. So there are penalties from CMS on 30-day readmissions, and that's publicly available. So you could even probably look at your own organization, but your quality people should know better. And you probably know too. But the penalties, I don't think paint the whole picture of the cost of the 30-day readmissions. It's really that not getting the payment on that second admission as well. So beyond what's published as the penalties, there's the other huge penalty that it has impact that it has on capacity. And I think an overall theme about virtual nursing too is the expertise that a virtual nurse can bring. And in like a virtual ICU setting, and I'll go back to UC Health again, they're covering 1,800 beds, 3 or 4 virtual nurses. And across the system, they'll see on average about 4 complex sepsis patients per day. And they are experts at complex sepsis patients, but that's across 12 hospitals, 1,800 beds. And a nurse in one of their satellite hospitals might not see that very often. And so I think all these, or even patient education, it's COPD is our bad readmission problem. So maybe it's a respiratory therapist, or it's a nurse that's doing patient education that's just expert at that and targeted at that, and that expertise brings up such higher quality, and that's where you can get measurable financial impact on the quality side.
Yep.
Time is flying, so let's quickly get through the patient experience side. And we don't want to see that it's fourth and last or least important in any way. Experience scores are so important, and we go into nursing, or we go into healthcare to provide good care and to help people in their time of need. And so there are also penalties with experience scores, that it's used as a negotiation strategy from payers. And so that matters to the revenue side. It can cause leakage into other health systems. And I think the really strong evidence that we consistently see from different emerging virtual nursing programs is that it always has a positive impact on patient experience. And so I've referenced a few here. A little shout out to Patricia Mook and Emily Cornelius from Advocate, who just presented this month at AONL, and they saw an increase in patient experience scores from the virtual nurse. Dana, why do you think that is?
I think because they can spend a little more uninterrupted time with the patients. I think when they're especially doing the discharge process or new medications, they really do have that time to spend talking to the patient, answering their questions, they're uninterrupted. And I would imagine that the patient feels a little bit more open to discussing with them because they know that like there's not a phone going off or an alarm going off, that they feel as though that nurse has to leave them and attend to other patients. I would imagine as a patient that would be a positive experience because I know that I have their undivided attention and I can feel free and comfortable talking to them and getting all the information.
Excellent. So those were the domains that we wanted to cover. We want to make sure there's time for questions. So anybody throw in questions that you might have. There were some questions on the time zone. I'm reading that. So somebody's going to have to watch the recording because they're like, oh, I'm on Pacific time zone.
It's early for you too.
Yeah.
Pacific time zone, yes.
That's why we don't call it a lunch and learn, because not everybody's eating lunch in every time zone. But I think we actually did have a slide with some of the most common asked questions. So maybe we could move through those in the slides that we had planned and keep an eye out for any questions that get typed in while we go through that. Oh yeah. So these are some of the frequently asked questions, and that Dana hears often, I hear, others hear, and we have some other sessions that this is part of a series that could address some of them. I do want to say something on who should I hire, session 1. So session 1, we talked about the role of the nurse, and I was co-presenting with Terry Hinckley, who is the CEO of the Academy of Med-Surg Nurses, and they just did a press release that their acute care virtual nurse certification is going live. And so look for that press release, and I loved being part of being asked to be a part of designing that the rubric for the virtual nurse certification that's coming out. And then what types of tasks? Last month we talked about that clinical resource telenurse. Next month we're talking about the expert oversight nurse, and we kind of dive down into the tasks and how many devices do I need to get started. Of course, that really depends on your model, and so doing the planning from this session today, finding out that information and deciding what target, what setting and where to target, and bringing your team together, then it's time to look at the technology and decide, what kind of device and what kind of platform to use.
Which is what I do for AvaSure. So with all of these questions that you have, we hear all the time, and that is how we can help you. That's my role. I have other nurses that work with me, and like I said, my IT partner. It's 100% free to you, so you should take advantage of it to get your virtual journey started. So we would, like I said in the beginning, we come on site, we talk through what challenges you're trying to attack and how we're going to do it, how we work together and work with your IT partners, your clinical partners, and do exactly what all those frequently asked questions in the previous slide was. What type of unit should we do if we're going to do a pilot? What type of device? What workflows? And part of our role is to map out a lot of your workflows. If it's an admission discharge kind of nurse that you want, we will go ahead and map out all the touch points from that admission and that discharge. So we make sure that it's very clearly identified how that virtual nurse will interject themselves into that process. But it really does help you kind of start your journey, get to know what your needs are. We can help coach you in through the business case and help you develop that business case. And again, align your IT folks with your clinical folks so that we're all talking the same language, the same timelines, and the same goals to move forward. So we're happy to help you with that.
Yeah, there's one good question here, and is, do you have a specific business case where you collected data and can demonstrate the outcomes from a financial and quality perspective? So at our symposium last fall, we had 2 presentations, and they talked about their outcomes there. I think it was mostly quality outcomes, and they had not put a dollar amount to that. And then we referenced the article from UC Health that you can have the link there. But next week there's an update. Next month there's an update on that with more data together. But I think virtual nursing in the acute care space is, especially out into the med surg, is new enough that there is a gap in the literature now. And so the 5 or 6 pilots that we have underway with Avasure are tracking all of those, and we can't wait to start presenting outcomes, but some of them are not to the end of their pilot phase yet. And I hope that it became clear as we talked through choosing your setting, choosing your model, where are your biggest pain points, how many different ways to do it. And so one kind of broad decrease sitters, decrease falls business case doesn't apply in the same way to virtual nursing that it does so simply and strongly in the virtual sitting side. But they're really in parallel and can work together in an adoption model really easily. And that's what we're excited to see over the next year. Did we run that last poll about whether you'd be interested to have Dana and her team come and visit? Because you were talking about it, Dana. Yeah. So if you would like to have Dana or one of her colleagues come out and do an on-site assessment and kind of help you walk through a lot of those questions that we talked about today, we would love to do that. And so just plug your answer in and we will be excited to do that.
Absolutely.
Dana has a lot of frequent flyer miles.
And I love to meet new people and hear new things. And it's just so exciting to hear some people's ideas of what they want to do from a virtual care perspective. So it's really great for the organization and for your organization.
Yeah. And then I think we're going to kind of close with the slide so you could see what the last sessions were, where you can listen to them, and when the next sessions are coming up. But
well, this was so much fun. Thank you for including me.
Yeah. It's always great talking with you, Dana. And yep, so it's kind of the same day of, it's the I believe the fourth Thursday at noon Eastern time. And so we wanted to do that consistently, but you can access recordings if you miss it. All right, thank you, everyone.
Thank you so much. Have a great long weekend.
Yeah, you too.